Hi, welcome to Virtua's Health Real Talk. It's women's health chat. My name is Nicole Michalik. I'm sure that I've seen a couple of you from the last one we did, and I am the afternoon drive host on 92.5 XTU, and I'm so thrilled to be here tonight again. Love Virtua so much. I love the fact that they do these and you're able to learn and speak to these brilliant doctors. So very excited to get started tonight. And first few hints for tonight's session. Okay, so your camera and your microphone are turned off, but you can still ask our panelists questions through the Q&A tab. So you see how fun technology is. You can kind of watch what's happening. You can choose to submit questions anonymously but like, listen, you don't have to be worried if it's you. You know what I mean? No one's going to judge your questions. This is what we're here for. And our experts are going to answer your questions toward the end of the session. A number of you have already submitted excellent questions for experts when you registered, and we're going to incorporate many of them into the discussion. Now, we get it. Sometimes you're watching, you're listening, you're learning, you're taking notes, and a question pops in. Don't worry about that. You can just type it in the chat, which is going to be awesome. Okay. So I don't want you to be like worried, like, what if, I have another question? We're all good. So if you prefer to have your closed captions on, just click the live transcript button at the bottom of your Zoom screen and select show subtitle. And then you can adjust the size of your font by clicking on the subtitle settings. Okay. Don't worry if you need to get your reading glasses. It's okay. You can do that too, but you could also change the size of the text. So if you see the closed captions at the bottom of your screen, and that means you're good to go. Cool. All right, let's jump into it gracefully since we don't want to hurt any of our hips or knees. I am very pleased to introduce the three experts tonight from Virtua Orthopedics and Spine Network of Specialists: Scott Schoifet, Andrea Bowers, and Thomas Plut. Dr. Schoifet is a board certified and fellowship trained orthopedic surgeon specializing in joint replacement. He is the medical director for multi-skeletal services at Virtua Orthopedics and Spine, practices at Reconstructive Orthopedics, and has been named one of top docs in Philadelphia from Philadelphia Magazine. Dr. Schoifet likes to travel, play golf, and attend as many New York Jets games as possible. Oh man, sorry about that. We won't hold it against you. He's been a very long time season ticket holder. Dr. Bowers is a fellowship trained sports medicine and shoulder replacement specialist and is the vice chair of surgery at Virtua Mount Holly Hospital. She practices at Burlington County Orthopedic Specialist. She lives with her husband and two children in her hometown of Morristown. One of my best friends lives there. Maybe you're neighbors and you didn't know it. In her spare time, Dr. Bowers coaches travel lacrosse. She is an avid tennis player and co-captain of two USTA teams. Her team is advanced to the national championships to be played later this month. Oh my God, congratulations. Yeah. We're not an overachiever here or anything. Dr. Plut is a sports medicine physician and sees patients at Virtua Sports Medicine in Morristown. His practice provides care to meet their patients' needs while delivering it through a caring and compassionate environment. In his spare time, Dr. Plut enjoys a variety of sports activities, spending time with his children and friends, and working on home improvement projects. So listen, if you see him at Lowe's, be like, listen, why am I in pain, doc? So welcome. I was kind of teasing everybody and I was saying, we're actually not going to talk about anything except how to keep our sports stars here in Philly healthy. How do we make sure Joel Embiid's knee is okay? That was, we always got to think, listen, even your Jets players, I'll even say, I know obviously your quarterback is having a rough go. So hopefully he comes back soon.
Thank you.
I do feel bad for some Jets fans because they had a tough go the last couple of years. Okay, so this is really cool. This time we have a polling question. Isn't that awesome? So the first polling question is: have you experienced pain in any of the following joints that affects your daily activities. And you could vote knee, hip, shoulder, or none of the above. And it's going to pop right up, which is really cool. So this is just basically a fun poll to kind of get a temperature, to get kind of an idea of how people are feeling. And again, it's, have you experienced pain in any of the following joints that affects your daily activities? And you could check all of them if you can. So again, that's knee, hip, shoulder, or none of the above. And I think people are just going to go, oh, look at that knee. Is this, doctors, is this pretty normal that you see knee as the most common pain?
Knee for sure.
It's definitely, it's up there. Yes.
Yeah. Because look,
100%.
hip and shoulders is, they're pretty close, but knee is really, there's like a big separation between knee and hip. So this is great. I'm excited to kind of get into this and learn more about it. Obviously,
what's scary is that only 4% have none of the above. That's not good.
yeah, I know. Okay. So what can cause joint pain in women? And obviously it depends on the joint. And today we're going to be focused on the hip, the knee, and the shoulder. And just so everybody who's watching knows that Dr. Schoifet is more of the knee specialist, Dr. Plut is the hip, and Dr. Bowers is the shoulder. How many shoulder surgeries did you do today, Dr. Bowers?
Today was just 3.
Just 3. So this is cool that we have these 3 awesome experts, and we're just going to start generally. So what can cause joint pain in women? And if Dr. Schoifet, you want to start, and then we'll do like knee, hip, shoulder, and kind of go from there.
Sure. So the knee is commonly the most injured. It's a tougher joint. It has a lot more ligaments in it that can be injured, a lot more moving parts. So with things that can affect the knee, you could have injuries to the tendons, which are the things that power the knee, the muscles and tendons. The ligaments, which hold the bones in place, could also get injured. And you could wear out the cartilage cushions in the knee, which could be arthritis. So that can be various types can wear that out. And so you could lose that cartilage cushion and have bone rubbing on bone. And outside of the knee, unfortunately, hip problems can cause knee pain. And even back problems like a pinched nerve can cause knee pain. So it can get pretty complicated to try to figure out what the source of the knee pain is in anybody, male or female. But we do see a lot more knee problems in women than we do in men.
And why do you think that is? Do you have any idea?
For me, it's interesting that osteoarthritis is more common in women in the knee than it is in men. About 60% of my patients will be women, and with hip arthritis, it's about 50-50. So it could be particular. The women generally are more active.
Yeah, women are harder workers. That's what it is.
Well, I was going to get to that, but I was trying to be delicate and protect my sex a little bit.
That's all right. I'm here for the colorful commentary.
But they do most of the heavy lifting, you could say.
Yeah.
Women also seek healthcare more frequently. They seem to be healthcare providers in the family, so they may be more likely to seek healthcare. And also, hormones and after postmenopausal, it could cause some of the hormone changes can affect the cartilage as well. And can maybe possibly lead to more arthritis. But the truth is, we really don't know why. It just is, and it has been that way steadily for years.
And the cool thing though about medicine, and why I love medicine, my joke is like, I just didn't like to study enough, but medicine is, you're constantly learning. You're constantly learning. So just because we don't know something today, tomorrow there could be a new study that comes out and we have a whole new idea of why something happens. Let me ask you this really quick before we move into hip and shoulders. Women tend to wear different kind of shoes than men. Could that affect knees and hips? Like if you're wearing, like, when you really think about it, a heel or a sandal or a wedge, men tend to wear like, regular just sneakers or flats all the time. Could feet issues affect your knees?
So I think the general belief is they affect your knees if you have a knee problem, but they don't cause the problem.
Interesting.
We see the shoe wear will affect feet, cause bunions and all other things. We don't have a foot expert today, so I won't go in that too deeply. But I get asked that a lot, especially after knee replacement. Is shoe wear going to have an effect? And fortunately, it doesn't. Where our joints are pretty resilient and they can handle the shoe wear. But once you have a joint that's not functioning properly, the shoe wear makes a big difference.
That makes sense. Okay, so let's move into hips and talk about, obviously, women, hips, childbearing, all that stuff. It probably factors in. And can you just talk a little bit about the difference between like men and women in hip pain and how that all kind of, how that differentiates?
Well, I mean, I echo a lot of the things that Dr. Schoifet said already. Just in my practice today for the women that I saw in the practice for hip, you know, there was arthritis in an older, in the older patient, but also we're seeing arthritis in younger athletes that have had injuries. So age, we're seeing just more arthritis at an earlier onset. I've seen that. They've had injuries or have had to have minimally invasive procedures. So arthritis is very common in hips, but also in the female patient, you see this in adolescence and moving around that age frame, is a condition called external snapping hip syndrome, where it's a tendon gliding over bony landmarks in the hip, and it can cause pain, and it can be during a young female's maturity and her cycle and everything as she's maturing and developing. So that would be an example that I saw today, and that's often treated first and foremost with physical therapy. So you see a lot of hip arthritis. Other things you can see in the hip, much similar to the knee, are tendon issues. In particular, the glute tendons on the outside part of the hip are commonly stressed and are often prone to developing pain in that area, more so than muscles in the front or back of the hip. So those are three examples that come off the top of my mind.
Yeah. That's really interesting too, in regards to, we're going to talk a little bit more about the arthritis and osteoporosis as down the line here. But when you bring that up, I guess before we get into shoulders really quick, when do you know it's time for surgery compared to, you brought up physical therapy? Like, is it more like with your MRI, your x-rays, like you just do that and you're like, oh, we've tried everything, like it's time to, like, we got to cut you open?
I mean, that's a great question. I would, you know, I need to mention, I'm not a surgeon. I'm a non-surgical sports med doc. So the patients that I'm sending to Dr. Bowers and Dr. Schoifet have often failed appropriate conservative measures.
Right.
Or, to be honest with you, surgery is the first and best option. You know, Last week I saw a patient for initial consult. After taking the history, I said, you know, you need knee replacement, you know, after they've failed multiple appropriate things. So, you know, that being said, a lot of times when patients are being sent from my office to a surgeon, they're pretty much sort of teed up for surgery.
Right.
That's the beauty of non-surgical sports medicine. That I don't have those tools. So if I don't have those tools, I'm going to use everything else that I can within reason to help the patient. And one thing that I did forget that I should mention, I mean, hip labral tears are common in young female athletes. And I'm seeing more and more of these injuries. It's been thought of, it's possibly due is because kids, be honest with you, are becoming one-dimensional athletes. You know, when I played sports, it was 3 months one sport, 3 months another sport, and you know, and you played multiple sports.
Yeah.
Now there's such an early sports specialization that one can say and think that that's causing more repetitive overuse injuries. So hip labral tears, that's the cartilage lining of the hip joint, are common as well in the young female athlete. But as the athlete or patient gets older, it becomes more of a arthritic degenerative tear.
Right. Yeah, that's so true too, in regards to, you have young athletes who are, it could be like overuse, but then they're just like, oh, I'm fine, I'm 20. And then they become like 50 and they never did the proper care. And then it kind of just like, you kind of live with it until it's too late.
Yeah, I mean, and then another important point is determining surgery. I think that's one of your questions. So probably maybe 10 years ago, if a patient with a pristine hip and having a hip labral tear came to me, I might be more prone to send them to surgery sooner then.
Right.
But as I've understand the literature and seen outcomes, I'm not as prone to jump to surgery. And I just saw a patient recently, she's in her 30s, she has a hip labral tear. And she basically drove her care because her first expression to me is, I don't want surgery. So what I worked with was physical therapy, strengthening with the therapist, strengthening her core and hip and everything. And then another option that we're considering is a PRP injection. And that's where we take the patient's blood and capture platelets to inject into the hip. Now, the purpose of these injections, I want to be clear here, is not to cure a hip labral tear. The purpose is to improve function and decrease pain.
Right, right.
So that's just an option. So a lot of times before we send them to surgery, I might try one of those two before we go off to surgery.
Yeah. I mean, listen, why do you think Peyton Manning ended up winning that second Super Bowl? Because got those special injections. Okay, Dr. Bowers, shoulders. Now, obviously I'm not a doctor, but women carrying bags, carrying babies, like this has to factor in, right?
Absolutely. So women are prone to the same things that men are prone to with respect to the shoulder, rotator cuff tears, arthritis with overuse. You get a tear of a tissue called the labrum, much like in the hip, and the biceps tendon attaches into the labrum. There are very specific subsets of problems, though, that are far more common in women. So I see young mommies who are carrying their baby in their non-dominant arm. That baby's getting bigger and bigger and bigger, and they're carrying around a 25-pound sack of potatoes, and their arm is bent and against resistance, and they get a lot of biceps tendinitis from that. Thankfully, that's usually self-limiting, meaning not something that would need surgery, something that if you correct, okay, put the baby down, switch to the other side, take an anti-inflammatory, just bring an awareness to them that helps. Females are much more prone to something called frozen shoulder. The medical term is called adhesive capsulitis, which is incredibly painful. It's the patient, when it very acutely happens, can almost look like they're sick to their stomach. The pain can be so bad. It's very common in females, and actually the outcomes are far better if you are actively seeking attention early on in the phase of starting with the pain before the shoulder becomes too stiff. You can also get calcium deposits in the tendons of the shoulder. It's called calcific tendinitis. Men can get it too, but it's more common in women. And then I'd say another more prevalent female issue would be what's called a fragility fracture. So specific types of fracture patterns that occur with bone density loss, like osteopenia or osteoporosis. One of the sites of a common fracture, besides the hip and the spine, is the proximal humerus, or the upper arm bone, which is the part of the ball that goes into the socket. Those are far more common in female populations than male populations with respect to the shoulder.
And the frozen shoulder, do you know what causes that? Or could it be genetics, or is it overuse, or is it just luck of the draw?
So there's kind of two broad categories. One is called idiopathic, which means we don't understand why this has happened. It just happened out of the blue, terrible luck, more common in females. It is a little bit more common in people who have metabolic problems like diabetes, thyroid disease, high cholesterol. Those have been determined to be risk factors, although not necessarily actively modifiable when the symptoms set in. You can also get what's called secondary frozen shoulder, where if you have something that's already irritating your joint, like a biceps tendinitis or rotator cuff issues, that the perpetuation of inflammation causes the joint to become chronically aggravated. The lining or the capsule of the joint, the deepest tissue layer, starts to become thick and unyielding, and it makes the joint stiff over time.
Interesting. That is so interesting. Here's what I think let's talk about the difference of bursitis, tendinitis, sprains and strains. That's always, or like a rotator, a tear. Like maybe each of you kind of could talk a little bit about all of that and how it affects different parts. Because that's always, people are like, I have bursitis, I have arthritis. Oh, it's just this. I'm like, what the hell does this all mean?
I can volunteer the knee if you wish.
Yeah.
So a sprain is an injury to the ligament. So one of the ligaments, so you have a medial collateral. Those are the ligaments that bond the knee together and hold it. So the anterior cruciate and posterior cruciate keep the bones from sliding, and the collaterals keep it from going side to side, and they get ruptured, and that's a sprain.
So the ligaments hold the bones in place, and then is the tendons are what helps things move, right?
Correct. You got it. So I don't even have to talk.
Important. I'll be taking patients tomorrow.
So the knee is basically like the bottom part of the tibia is a flat plate, and the top part is basically is the cylinder that rotates on it. And so to keep it from sliding around, you have the ligaments hold it together.
Okay.
And so it's a complex joint, which is also why it can be injured. So a strain is an injury to the muscles, and the muscles are what power the tendons. So you have the muscles and the tendons. The tendon is the thick part that attaches, and that's what moves the joint. So when you have a strain, you're tearing the muscle. And if you tear the ligament, that's a tendon rupture. So you can rupture a tendon and strain a ligament. And to get more complicated,
Don't
as
you
the
feel
tendons,
so
as
smart?
the one,
Everybody
there's
that's
one more
watching,
level.
so smart.
So the tendon
Love
will
it.
rub over the bones.
Okay.
And so it doesn't rub on the bones. Between the tendon and the bone is a fluid-filled sac called a bursa, so
Okay.
that the tendon can rub smoothly over the bone.
Right.
And it's on most of the tendons. And so an inflammation of that is called a bursitis. So now you got bursitis, tendinitis, strains, and sprains, all defined. You can
And
get them
what-
all in the same joint.
And so the arthritis is more of the bone.
Okay,
Where-
so that's a new one. So arthritis is the loss of the cartilage cushion. So
Okay.
the best way to think about this problem in your knee is if you think of it as the tire of a car, right? And
Okay.
the human being, you're the human car, and you got your 4 tires, your hips and your knees, and the tread of that tire and the tread of your knee is the cartilage. So the bones are not meant to rub together. And so the wearing out of the tread of your knee or your hip is like wearing out the tread and the tire of the car. And as if you have a little bit of wear, it's mild arthritis. But when all of the tread is gone or all the cartilage, the bones start to rub together, and that causes pain and inflammation. And so that's when the arthritis starts to be more noticeable, and you have to treat it. And if you keep wearing it, it's sort of like now you've got a blowout of your tire and you're riding on a flat tire. Well, the car doesn't drive very well on a flat tire.
Oh, I
And
know.
that's when you start rubbing the bone away. And then eventually, it gets all deformed, and that's sort of like you're riding on the rim. So that's all fixable, but it's also treatable. You can treat the early stages of arthritis, but once the tire is flat and blown out, that's where the surgeon comes in, and we basically retread that tire.
Oh, wow. That's
That's a joint
So-
replacement.
the goal should be as soon as you feel pain, and I'm assuming with the shoulders and the hips and the knees, it's all ligaments, it's all tendons, right? So it's the same theme. It's just obviously different parts. So as soon as you feel pain, you should go get it checked out immediately so you can diagnose what's actually going on, so you can kind of get ahead of it.
That's 100%. And so that's where we all come in our own fields, is that as soon as you have pain, figuring out what it is. Is it arthritis? Is it a tendinitis? Is it a bursitis? Is it a sprain? Is it a strain? All these things, that they all cause pain.
Right.
But that's where the diagnosis and us trying to figure out what it is, and the treatments for them are all very different. And each joint has its own categorization. I'm sure Andrea and Tom and hips and shoulders, they all have their own individual problems related to those things.
Right. And also, like, every body is different. So I'm assuming that plays such a huge part too, right? Like it's fascinating when you really think that there's only one of us, we're entire genetic makeup, and there's 7 billion people in the world. And the people are like, oh, identical twins. Well, all right, for all intents and purposes, we're all different. And that's really fascinating too. So just because somebody might have something that is similar doesn't necessarily mean it's going to be the exact same in anybody else.
Nicole, for orthopedics, short of the spine, the beauty of the body is that there's supposedly symmetry. So you have a right hand and a left hand, and a right hip and a left hip. And if your right hip is different from your left hip, you have to find out why. What's the differentiation? So you're right. You don't compare me to Dr. Plut, but I compare my right to my left. And if you notice a difference in the comfort, the function, the strength, the range of motion, then it is time to get checked.
Yeah. And would you say that it should be an age? Like if no one's having pain, and then let's say they hit 40 or they hit 45 or 50, or is it more like if you start to feel a discomfort, you should go and start to get it checked? Like, is there a way to like scan your whole body to be like, you're good, or like, ooh, I see some bursitis creeping in? Like, is there a way to tell that?
I think that's a slippery slope. I mean, you might find some information that would lead you down a path that isn't necessary. I do think screening studies are important for other medical issues, and maybe from orthopedic perspective, getting screened for osteoporosis is incredibly helpful. But if you feel well about how your body is functioning, I don't necessarily think that there's a need beyond seeing your primary care physician for your annual checkup to necessarily run to the orthopedist or the non-op sports doc.
No,
Yeah.
but you guys are so smart. I'm like, I'm coming tomorrow. Check my
Yeah,
hips.
I agree with Andrea. I think you want to have appropriate testing as opposed to over imaging and stuff like that.
Right.
So, and also sometimes not having information can be actually beneficial to the patient. Like if they find out incidentally that they have, say, a little bit of knee arthritis and the issue was maybe tendonitis, that could change their activity level, and it might not be the best thing for them.
Right. Yeah.
So more information is not necessarily better. So
That makes sense.
Also, I think, Nicole, it's also appropriate how the physician conveys the information to the patient.
Right.
A lot of times, as physicians, what we do is offer reassurance.
Right. So is there ways for people to prevent injuries on our joints?
Well, I mean, a common thing that comes, that's a common question in my practice. I'm going to be honest with you.
Yeah.
And I have to talk about it. It's our country's becoming overweight and obese.
Right.
It's a sensitive subject, but I have helped the patients the most by, now granted, I'm not trying to get them down to what their size was when they were 21.
Right.
But the studies are clear on this. If you can get your patient to lose 10 to 15 pounds, their hips, their knees, their back, their body's going to feel better.
Right.
So a common thing in my practice is I do discuss diet. And one of the things I emphasize is how carbohydrates, too much processed foods, are leading to obesity. And so I've, over the years, been able to help patients lose weight and keep it off. But it takes time. And also, more importantly, the patient has to be willing to make changes in their life.
Right.
The physician is sort of like a cheerleader,
Yeah.
a coach. So one thing that I try to do is, one, not get them to put on any more weight.
Yeah.
So that's one thing. Two, I try to get their pain controlled, whether it's shoulder, hip, knee, foot, ankle. Try to get the pain controllable and then get them on some type of exercise routine. But I also stress the importance here is most people don't realize this, that people put on weight in this country, they think it's because of a lack of exercise. Actually, that's 30% of the problem. 70% of the problem is the food in their diet, to be honest with you. So you have a problem that we can talk about it, whether it's a female in their young 20s or older, they're overly exercising.
Right.
And they're only addressing 30% of the problem.
Right.
They're not addressing 70%. So then they get these injuries that are often detrimental. And then it causes this horrific spiraling down of inactivity. And it's rather hard. So I think you have to have a balancing approach when you would discuss these issues.
Yeah. Yeah. Because I think that there are a lot of people who don't realize how fast this, I mean, we do live in a very sedentary society at this point, which is unfortunate. I mean, I live in the city, so like, I love the fact that I get to walk everywhere, but like, if you don't, like, you literally just are driving and, and there's the access, and especially like with COVID and how everything was available to be delivered.
Yeah.
And so, and then, this could be a whole other,
we could talk.
Yeah. And
So,
people overworking and spending too much time at work and not enough time for their overall mental wellness and physical wellness. It's a huge conversation to have. But yeah, I think a lot of people we also live in a very quick fix society. So they just think like, oh, let me just like get an injection. And you're like, well, no, how about we try to like walk 30 minutes a day first?
Yeah, I had a patient within the past 3 years. She went from weighing 350 pounds. She's now at 180.
Wow.
But she took ownership, and I was basically a cheerleader.
Yeah.
And I'm going to be honest with you. She went from not exercising at all. And every visit, I'd say, "How about 10 minutes on the recumbent bike?"
Yeah.
You know, now she's doing 30 minutes on a recumbent bike, which every day that prior to this, she could have never done.
Yeah. And it does. I mean, the reality is it does suck because there's a lot of people who eat whatever they want and are thin. And that's just the reality, right?
Yeah,
So,
I have to.
so those jerks have that's a whole lot. So before we get into, because there's a lot of really great questions coming in.
Yeah.
Let's just talk really quick about, what are, I guess in regards to like, if surgery is needed, is it invasive? Is it minimally invasive? Talk a little bit about the technology, because I think people get scared when they hear the word surgery, and they think they're going to have this like massive cut, and then they're going to have to go to physical therapy. And, sometimes, yeah, if you have to get a full hip replacement, this might be something that you have to do, but there's the advancements in technology are phenomenal. So look, can we just talk a little bit about the surgery aspect just to get people informed on that?
Sure. I think I could address the knee because it's probably the most common, and this will relate to the hip as well. There's been huge advances in technology, especially since I've been doing this for like 35 years. So things have changed remarkably. From when we used to cut the patient open, they'd be in the hospital for a week, and then they go to a rehab center for 3 weeks. Now we're doing surgeries and outpatient and send them directly home. And a lot has to do with our understanding, and a lot has to do with the technology. The understanding part of it is in those days we used to do the surgery and immobilize the patient, figuring things had to heal. And then we've learned since then that activity and motion and getting up and walking helps it heal faster. So we've learned to protect the tendons and the ligaments, and that's what minimally invasive surgery. For a knee, you have to move the kneecap out of the way, and you have to cut that big quadriceps tendon to get into the knee. Now we have ways of working around it and protecting it. So the terms minimally invasive surgery for hips and knees means not cutting the major tendons and working around them so that the patients can rehab themselves before surgery, be strong, and be able to use that joint right away. We have better ways of managing their pain. We learned a lot more about, rather than just giving people pain medicines, to use anti-inflammatory medicines, ways we can block certain nerves and keep them more comfortable. And then the technologies have changed remarkably. The implants that we put in now, the patient's bone grows into the implants rather than using cement. We do that with both hips and knees so that they can last much longer. So you can do many more active things with them. We have robotic assisted surgery. So we're able to know exactly the patient's anatomy.
Watch out, robots are coming for your jobs.
We still control them, we like to say. But there isn't a single field that robotics hasn't entered that hasn't transformed ever. So it's doing that in medicine now, it's doing it in surgery. So we can now make custom implant the knee to you. Like Andrea said, the shoulders are, everything is different. The left and the right could be a little bit different. Every patient's knee is different. So we don't put it in the same way with everybody. And that together, not only have we gotten patients in and out of the hospital, or patients to be able to have surgery and go home an hour and a half later, but we have implants now that if they're implanted when you're 40 and 50, we expect to last your lifetime. Whereas years ago, if you got 10 years out of your knee, it was a miracle.
Yeah.
So, so now we're looking at being able to do these things to younger patients with arthritis. And that technology is transferred to hips as well as knees, and I'm sure with shoulder replacements as well.
Yeah, the shoulder, I'd say the need for a shoulder replacement is much less frequent for sure than for hip and knee. And a lot of our shoulder surgeries are minimally invasive, meaning arthroscopic. So done through a camera lens that's inserted through a very small incision, usually about a 1/4 inch long. And maybe it would require 3 of those to accomplish, for example, a rotator cuff repair or a labral surgery or a bicep surgery. And so instead of making big, large incisions and moving muscles, you're guiding things between muscles, and therefore the adjacent tissue trauma is much less, the pain is less, the recovery is a lot easier, on top of the fact that the cosmetics are just better. There are certain injuries that, of course, require surgery right out of, right off the top, like certain fractures that are out of position, or dislocations in a young athlete where the anticipated risk of redislocation is very, very high. Certain injuries where the rotator cuff becomes acutely, completely detached. Those require surgery up front. But for the shoulder, many of the problems are usually tackled non-operatively first. Maybe activity modification, physical therapy, anti-inflammatory medicines, judicious use of injections. And then if those issues fail, usually MRI helps guide us as to whether camera surgery could be helpful, or if it is truly arthritic, bone on bone, that's when we consider shoulder replacement. And that is done through an open incision, but as Dr. Schoifet said, outpatient procedure, come in and go home the same day. And then there's another type of replacement that is now available since 2004 in the US called the reverse shoulder replacement. And that's kind of been a game changer, because that's given us a solution for patients who have irreparable rotator cuff tears or end-stage arthritis that weren't fixable by traditional means. And that's been probably the hugest advance in shoulder surgery, I'd say, in the last 20 years.
Listen, my Uncle Tony just got her shoulder replacement last year, and he's like, this is the best thing ever. Take me to the golf course. Like, he just like, I'm like, we get it, Uncle Tony, you're feeling better. So I think people have to, I think what happens a lot of times is people live in pain for so long, and then they get scared to think, is this really going to work? And then all of a sudden they do it and they're like, whoa, I feel awesome.
Yeah.
All right, let's get some questions, because they're really, they're coming in, and there's some really good ones. Okay, so this says, I had a steroid injection in my knee on September 1st, no change for 4 days. Then the constant ache finally went away for 3 or 4 days. After that, the pain returned. So the shot isn't going to help.
Well, that's a complicated one, because we don't exactly know what's wrong with the patient,
Right.
or what the shot was for. So if it was for arthritis, to me, that would be telling, in that if the pain went away right away, that tells you that the problem is coming from the knee. As I mentioned, sometimes other things could cause knee pain, like a back problem or a hip problem. So an injection would never give you any relief at all. So it helps me with that. But sometimes if it's an arthritis problem, sometimes your arthritis is so bad that shots aren't going to work, and that you have to do surgery. Sometimes there's other things that could be affecting it, like if you have the arthritis, but the patient's very weak. And I mentioned how the car analogy, where you have a bad tire in the car, well, now you have a bad tire and a dead motor in the car.
Right.
So there's more things wrong. And so some of these things can be addressed, ahead of time. So you may want to put that patient through physical therapy, or give them an exercise program to fix that. And maybe then the shot will help. So there's other things that could be affecting them. So it is a great question, but that's a difficult one, because there's still a lot of hope for that patient. Because if it is for arthritis, there may be other things that are bothering that knee, affecting it, as I mentioned.
Yeah.
The strength could be a big issue.
We talked about this a little bit, where it said, I'm in my 40s, I experience achy knees and hips, but it does not prevent me from my daily activities. Is there something I should be doing now to prevent surgery in the future?
So I could direct that to Dr. Plut, but we probably have the same agreement that exercise would probably be our number one choice for a patient that's complaining of those sort of problems, or they can't do everything they want. Most of the time when they have pain in the joint, they're not going to use the joint. They're not going to use it to go upstairs. They can't go for long walks. It's the only thing that makes them feel better. But by taking that joint out of circulation completely, it starts to lose power, because you're not using it for daily activities. It's sort of like you've been in a cast. And then when you start losing your strength, it's going to magnify those problems in that joint. So trying to find a low impact exercise, whatever joint, that the patient could do to bring their strength back to normal, is a lot of ways to get rid of these aches and discomforts. Because a lot of it becomes secondary to the pain. By resting the knee, you've created a second problem. And sometimes the second problem can overwhelm the first.
Yeah.
And by addressing that, you get better.
a good question regarding exercise, because there's a lot of super intense exercise. Obviously, CrossFit is huge for a lot of people. You have extreme boot camps. You have people that like are doing, you know, all these like Ironman, or they want to do, you know, the, what are they called? Like not the mud runs, but the warrior runs. Like is
Spartan runs.
Spartan runs. That's the word. I couldn't think of it. So is it basically you're just like, every person just has to see how they feel? Because I have two friends that had to stop doing CrossFit because one hurt their knee and one hurt their shoulder because it was like too crazy. So
Nicole, I'm sorry. CrossFit is well documented. It is a risk of injuries. That's just,
right.
I'm gonna be honest with you. I've been to various lectures for the past 10 years, and there's a running joke that CrossFit is good for doctors' business. I hate to say that, but I see a lot of so to you know, be honest with you, you know, a lot of these people think about it. They start with CrossFit. It's because they're in a different season of life. Say, you know, the kids are older, they're in middle school, and now parents or, you know, significant others, they want to start working out. So, but prior to this, they weren't really moving that much. So they think they can go back to what they were doing in their 20s as they were having kids.
Right.
So their body physically cannot meet the demands that they're putting it under. Number one.
Yeah.
Number two, what we know from the data is people start developing arthritis regardless of injury.
Right.
Because none of us can defy gravity. So when you're talking with these patients, and I even talk with my CrossFitters or my one-dimensional athletes, you know, the person that's, well, doctor, I've been running for 20 years and my knees are bothering me. Well, to some extent, they've done too much running and they have arthritis. So now I have to work with the patient I sort of have to be a good salesperson here.
Yeah.
I have to sell it that they have to do other activities.
But not crazy.
No, exactly. So
yeah,
I'll just my own life. So this week I've ran, I've cycled, and I've done resistance training and core workouts. Because what I learned 15 years ago when I was solely just running, I was having runner's injuries.
Right.
So I had to make changes in my own personal life. And what I've done is help me, so it helps me sort of convey that message to my patients. So,
this is a really good one, Dr. Bowers. Are shoulder issues more common in women with dense, large breasts?
I would say absolutely. So the shoulder itself is a very complicated joint that's based on the shoulder blade or the scapula. And the scapula is tethered to the chest wall, and it has forces that work across it. There's 17 different muscles that have to coordinate how the shoulder moves in space around the shoulder blade. And the chest will pull on the front of the shoulder blade on a prominence called the coracoid and roll the shoulder blade forward. It's kind of like a hunched effect. That hunched effect then effectively puts the blade in a bad position from a pressure perspective on the rotator cuff. And then the rotator cuff becomes irritated, or the bursa sac becomes inflamed. And then you can have this domino effect that goes from there. And it's not just dense breast tissue. I think it also comes from core issues. So we women have had babies, we maybe had C-sections, you've maybe had a hysterectomy, and your core is not as strong as it once was. And again, that core gets you up and back, your shoulders back. When your core is weak or you have the weight in your chest, again, you're rolling forward. So it's all about a posture and mechanics kind of thing. And some of it's correctable with exercise and physical therapy and diet, and some is not. And so I actually do sometimes have consultations for women who are considering breast reduction surgery based on, you know, musculoskeletal issues that they're having related to that. And some insurance carriers even require documentation from an orthopedist as one of the steps that they have to take to get authorization.
Here's another shoulder question that's interesting. Does a frozen shoulder secondary to a torn rotator cuff mean that it will not get better until the torn rotator cuff is repaired?
It's a great question. It depends on the extent of the tear of the rotator cuff If it's a partial tear, I would always try to treat that conservatively. That is when there is a frozen shoulder component, that is one of the reasons I might consider an injection right away, like block that inflammation. So a steroid is an anti-inflammatory. So I would start with an injection, calm down the inflammation, and give them a chance to succeed in physical therapy to work on stretching out the capsule and then rebalancing those forces across the rotator cuff. Now, if the rotator cuff has a complete tear and the shoulder has become frozen as a result of that, and the joint is not arthritic, then you do have to address both issues. So if that would be a surgical indication where we would fix the rotator cuff, but I would also take a lot of time to actually intentionally loosen the capsule and stretch the shoulder out before I would reattach the cuff to make sure that the tensioning is correct. And in those cases, I might be more aggressive about getting my patients into physical therapy earlier in the postoperative phase.
There's some really good questions. Here's another interesting one. I take 1 magnesium tablet a day, which has made my shoulder pain disappear. Should I still get it checked out even though I'm no longer in pain?
I think that maybe you would talk to your primary care physician about why you may be needing a magnesium supplement. That's where I would start.
And then this also kind of goes with it. What is your opinion on glucosamine? Hopefully I'm saying that right. Supplement.
Glucosamine.
Glucosamine. So close. And does turmeric have benefits on the joints?
So the data on glucosamine is hit or miss, meaning there's a strong placebo effect with that supplement. So patients that get it and take it and they feel better, it's pretty harmless. I allow them to keep taking it. But the data on it is equivocal. Maybe it helps, maybe it really doesn't. So we're on the fence with that supplement. In terms of turmeric, there is data published on this because it's an Indian spice, heavily used in India. It has strong anti-inflammatory properties. So a lot of the chronic pain physicians in the US, they're supplementing their patients with turmeric or curcumin. That's when it's mixed with black pepper and bioperine, and that's how it gets maximally absorbed to treat chronic pain and inflammation. It's safe, it's effective. It does have some side effects such as upset stomach, maybe some loose stools, but that's rare. So it does have some benefit for treating pain and inflammation, yes.
Here's another really good one. I had my left knee replaced. Is it still possible to have a ligament tear?
So that's an excellent question. It is. When we do a knee replacement, we do remove 1 or 2 of the ligaments called the cruciate ligaments, the anterior and posterior cruciate. So if you remove it, you really can't tear it anymore. So some of those don't exist, but the ligaments on the side, which we call the collateral ligaments, can be damaged after. It's not common, but some people go back to vigorous sports and skiing. And if you wipe out on a set of skis with a knee replacement, you very well could tear one of your ligaments. A tendon tear is more common after joint replacement. The big tendons are the quadriceps and the patellar tendons are the ones that attach the kneecap. And those are sort of what we consider catastrophic injuries. If you tear one of those, it's usually a major fall. And it's difficult to repair.
My best friend tore his entire quad muscle. He slipped on the steps in socks.
It's easier to fix without a joint replacement in place, because once we do a joint replacement and we mess with them and then you tear them secondarily, and they're the motor of the joint. So it's if you can't get it fixed and the fixing doesn't work, you can lose the function of the knee, which is sad. So we do recommend caution after a knee replacement. With some of these, we tell people don't be jumping off of ladders and things that could cause those big injuries. So unfortunately, it can still injure the parts that remain after a joint replacement.
Here's interesting. I've been diagnosed with osteoarthritis. Does it migrate to the entire skeletal system? Is that true or not true? And can a stem cell treatment help pain and bone degrading?
So
feel that, Tom.
All right. So stem cell research, though popular, the data is very, very weak. I've looked into offering this to my patients, but we're not there yet. I was at a lecture not too long ago, and I met the guy that coined the term stem cell, and we're now questioning whether we're actually getting true stem cells. So I would say I would caution any of my patients to get stem cell, one, because it costs $3,000 to $6,000 per injection. I think it's right now, I don't think we have the data. That's why I'm not offering it. The data is stronger with PRP, which is by far a lot cheaper and more cost effective for the patient. So I usually go with things that have some data behind it. The stem cell, we're not there yet. And I'm in good faith, I couldn't offer those to my patients right now.
Unless you're Andrew Luck and Peyton Manning, who went to Switzerland for the special surgery.
Well, I think the three doctors on this panel, we treat a wide variety of socioeconomic status. So I think that's why we're sort of in our branch of medicine where we're at.
Yeah, which is amazing that you're trying to help the average person who doesn't make $100 million a year.
That's why I at this point I couldn't offer that stem cells, because all you can do is treat people with money. And I don't know, I have some issues ethically about that.
Yeah.
Nicole,
oh, sorry, go ahead.
Oh, no, it's okay. I tell my patients with stem cells for knee arthritis that the only thing it's going to affect is their bank account.
Well, that's probably
There's a reason insurance doesn't cover it.
Yeah.
Yeah. What are your opinions on cartilage supplements, powder or liquid, to help with minor joint discomforts? Are they bogus?
We don't have any good evidence. At this point, I'm not against it. That's a common question that I get in my practice. I see a strong placebo. So some of my criteria are, is it a risk-benefit ratio? If they feel better and it's not hurting them, and they're moving and they're taking less Advil, Motrin, Aleve, then that makes me happier, because those medicines have a higher risk of hurting kidneys, liver, other organs in the body. So it comes down to a risk-benefit ratio.
Interesting. All right, let's do one more question. I have adrenal insufficiency from steroids from adult onset asthma. I have pain in the shoulder muscle compartments and severe weakness. My rheumatologist thinks it's steroids myopathy. Is there any treatment to help? Ooh, that seems like a lot to unpack here. Quite an onion question.
That is a lot. So one of the long-term problems that we see with steroid use, and certainly there are certain diagnoses that require steroids and need them, but if with long-term use of steroids, it can put you at risk, in particular for something called osteonecrosis, which is where it's kind of like almost a heart attack to that organ. So loss of blood flow to the end of the bone. So there's lack of support for the ends of the cartilage, and that can essentially over time cause the cartilage to collapse. And it's kind of like Dr. Schoifet's flat tire scenario, where it turns into basically arthritis. That's probably the most common effect that I see in the shoulder joint from steroid use. With injectable steroids, it's a different situation, but with injectable steroids, you can see traumatic tendon ruptures. I don't commonly see muscle like myopathy effect from steroid. The other thing I would question is there any potential underlying rheumatologic issue that's affecting the joint? If people come in and they have multiple body parts affected, they have, for example, like adrenal insufficiency or other like endocrinology or metabolic issues, you'd want to consider doing a rheumatoid panel, screening them for rheumatoid arthritis, lupus, Sjogren's syndrome, like medical problems that can reflect as joint-related pain or dysfunction.
Awesome. So before we close, because it's crazy, it's almost 8 o'clock. Woo, time flies when you're learning. Do either of you have any advice or tips that you would like to share with our attendees? Dr. Bowers, you want to go first?
Honestly, if you could narrow it down to one thing, use it or lose it. I mean, keep moving. Joints want motion. They want lubrication. They want They want to be active, and it's all within reason. So if you could target 30 minutes a day, every other day, within moderation, give yourself a rest day, but keep your body moving and keep your core strong. Like I talked before about how your core affects, your shoulders, but it also affects the support of your spine, your balance. It can help prevent falls. So keep moving and keep your core strong.
We'll be doing a virtual Pilates class real soon.
I would say much of the same thing. Keep moving, but also have variety in your life with exercise. And try to get outdoors as much as possible.
So I'll speak to knee arthritis because that's most commonly what I see. And I think a tip is that just because you have arthritis doesn't mean you have to have surgery. That there are some really great non-operative treatments for osteoarthritis. And just because you have the diagnosis doesn't mean you have to have something done right away. My goal is to actually, when I see a patient, is to not operate on them, but to give them a pain-free joint. And so there's a lot of things we can do to keep them pain-free. And your own knee, if it's pain-free and fully functional, is better than any joint replacement I can give you. But as soon as your joint replacement is painful and not working well, then my joint replacement is best for you.
Yeah. And how lucky are we that we have really brilliant doctors and surgeons who study this all the time. And I was just watching the TV show the other day, and they said, don't forget that an object in motion stays in motion and an object at rest stays at rest. I'm like, God, it's such the simple law of physics that we forget sometimes, that when you just are and that's anything, just as something as simple as just like walking around the block and the weather start to get crisp again. We could listen to a podcast, download the 92.5 X2 app. You can listen to me anytime. So if it's, just as we close, we want to remind everybody that it is your body. And if it's not functioning the way you want, that there's help. And that's why Virtua is so amazing. And why we're doing this is because, as you can see, there's a network of over 60 specialists that provide specialized care. And I think a lot of people sometimes get anxious or they get scared of going to the doctor. And it's so important when you have these amazing people at Virtua that want to help you. A recording of this session will be emailed to you in the next week, which is amazing. And at Virtua Orthopedics and Spine, we understand the importance by finding a specialist who focuses of your specific condition. So with our team, you're going to gain access to over 60 specialists and surgeons providing specialty care for a full range of orthopedic conditions. And with clinical and surgery locations available throughout South Jersey, care is literally right in your backyard. So for more information or to schedule an appointment with Virtua Orthopedics and Spine specialists, and look how fun these brilliant doctors and surgeons were today. I think a lot of people think, oh, they're too smart. They are smarter than most of us, but that's okay. They're going to help you. So you just go to virtua.org/ortho. That's virtua.org/ortho. Thank you so much for all the awesome questions. I'm sorry that we didn't get to all of them, but obviously we're even going to run over a couple minutes, but there will be call up, make an appointment, and there'll be a transcript. And again, thank you for all the questions. And yeah, Dr. Schoifet, Bowers, and Dr. Plut, another real talk session. So thank you very much. And go Eagles and Phillies.
Yeah. And Jets.
Hopefully, Zach, listen, I like Joe Flacco is from South Jersey.
Oh, come on.
He's from South Jersey.
He's a little too slow now.
Well, that's what I was going to say. Will Zach Wilson's meniscus heal up? How long is it going to take for the meniscus to heal?
Oh, it's his bone bruise that's slowing us down, not the meniscus. Yeah.
We need to do a special one just on sports, because I'll have a million questions to ask you because I love it.
We should. Sports in the knee. It's a big one.
Yes. Thank you so much. You're all so awesome and kind and brilliant. And that's why Virtua is the best. So thank you, everyone, and have a good weekend.
Thank you, Nicole.
It was good. Take care.
You too.